So I'm going to talk about clozapine today. It's been on my mind from some recent patients. So clozapine, it is considered a second generation antipsychotic, and its mechanism of action is poorly understood. We know some of the receptors that it binds to and things like that, but how it actually works and why it works so much better than other antipsychotics is still a mystery. So, when do I think about using clozapine? Well, if someone has tried, let's say, two or three or more other antipsychotics and they've got a schizophrenia spectrum disorder or even severe bipolar disorder with psychotic features, then I am thinking about clozapine. So, I'm usually not going to be jazzed about clozapine if someone is homeless and they've got no family involvement and they're basically discharging to shelter or something like that, because they need to have someone that can help them out, someone that can make sure that they're getting their blood tests and all of that, which we'll talk about. So if someone is in an institutional setting like a group home or something like that, or they've got family involvement or they live with family and they've tried even just two or so failed antipsychotics, then I'm already thinking about clozapine because I have seen it do miracles for folks where conventional antipsychotics didn't work. So clozapine has a number of rare but serious side effects, and that is why we don't use it first line primarily. I think some people find it to be a scary medication to use because of that. So let's talk about the black box warnings. So black box warnings. So these are the warnings that are literally in a black box on the manufacturer label for the medication. And there's 5 of them for clozapine. And I come up with a little mnemonic for them. And then the mnemonic is close, CLOSE. And you can remember that by thinking to yourself, you need to keep a close watch when someone is on clozapine. Okay? So C stands for carditis. And specifically, we're talking about myocarditis. So this is inflammation of the heart that can rarely happen with someone on clozapine. And so you've got to be really attuned if someone is complaining of chest pain while they're on clozapine. Or if you really have high suspicion, like they've got other symptoms other than chest pain, like fevers or anything else that raises your suspicions, especially if the chest pain is sort of positional, then it's probably a good idea to consider holding the clozapine and sending them to the ED to get a troponin, an EKG, and things like that. So I've only had to do that once or twice with my folks on clozapine. So at least in my anecdotal experience, it's been rare. And I've never had any of those patients that I sent to get evaluation actually turn up to have myocarditis. But that is a obviously potentially lethal side effect of clozapine. So that's C in close. The L stands for lymphopenia. Okay, so lymphopenia generally just means like low white blood cell count, right? Now, that's not exactly accurate. So clozapine specifically causes neutropenia, so low neutrophils. And so we're particularly looking at the ANC, the absolute neutrophil count on a CBC, but that was sort of the best I could do with my mnemonic. And I think that's pretty easy to remember. Lymphopenia, we're, thinking about neutropenia. Neutrophils are, a type of white blood cells. Okay, so that's the thing that we're most watching out for because we're doing weekly CDCs, weekly complete blood counts when someone is on clozapine for the first 6 months. And that's because we need to watch out for that neutropenia. Now, you might have heard that the FDA has removed the REMS program for clozapine, and that is correct. So there's no more REMS program, and REMS stands for Risk Evaluation and Mitigation Strategy, I believe, and it's basically a program that's attached to a number of medications, many of which are not psychiatric medications. So this is not unique to clozapine. for example, Spravato is also in a REMS program. It basically just means this medication has extra risks and requires additional monitoring and documentation. So for the case of Clozapine, the REMS program said we had to do weekly CBCs, and that had to be entered into an online system, and the pharmacy wouldn't be allowed to dispense the Clozapine if the patient hadn't had their CBC done or if it hadn't been uploaded into the system. So that is no longer a requirement. However, the clinical recommendations for Clozapine are still the same. The recommendation is still to get a weekly CBC for the first 6 months. And so that's not any different. It's just that we're not required to upload it into the system, and the pharmacy is allowed to dispense it without that CBC being done. So I would still recommend that we do the weekly CBC according to the guidance for the patient's best interest and also from a malpractice standpoint. But, oftentimes these things aren't perfect. And so if you have a patient who's been doing really well on Clozapine, and that's the one medicine that sort of keep them out of psychosis and functioning well, but for whatever reason, they happen to accidentally miss their weekly blood draw, then, you do a risk benefit analysis and you say, well, they're like 5 months in, they've been tolerating it really well. There's no trend for the ANC going down over the last CBCs. So we're not going to hold their Clozapine just for this reason. And we'll just try to get that CBC done as soon as we can. So that's that. So moving on to the O in the close mnemonic. So O stands for orthostatic hypotension. So Clozapine, one of its mechanisms is it's a potent alpha-1 adrenergic receptor antagonist. And the alpha-1 receptors are responsible for, for a number of things, but particularly vascular constriction. And so if you block it, your body will be unable to constrict its blood vessels effectively, especially when you're making sudden movements like getting up from a seated position. And so people can get severe orthostatic hypotension and pass out. They can have syncope. The box warning actually talks about cardiopulmonary collapse in the worst case. So this is the really serious warning as well. And this is actually the reason why we have to dose Clozapine very carefully and ramp up very carefully. It's not really the neutropenia, it's the orthostatic hypotension. So for Clozapine, I typically start at 12.5 milligrams twice a day. So the recommended starting dose is either 12.5 the first day or 12.5 milligrams twice a day the first day. And then you can increase the dose by 25 milligrams per day, potentially up to 50 milligrams per day until you get to your target dose. So we're starting out at a very low dose that is nowhere near the typical therapeutic range. But because of that risk of orthostatic hypotension and syncope and cardiopulmonary collapse, that is what we have to do. The other thing is, let's say someone is up to a therapeutic dose and they've been on it for a while and then they miss some doses. Okay. So if they miss more than 2 days of their Clozapine, you actually need to restart the ramp. Now, if they've been on Clozapine for a while and they've been tolerating it well, then you can ramp up more quickly than you did the first time around. But over 48 hours of missed Clozapine, you're supposed to restart, at the lowest dose and ramp up. And that's because your body, even after just 48 hours, has lost its adaptation to the alpha-1 blockade. And so it's resensitized to that alpha-1 antagonism. The other thing to be aware of is that if you miss just 1 day, you should restart it at half the dose. So if the patient was at 300 milligrams a day and they miss a day, then you should restart the dose at 150 milligrams the next day, just because they've already lost some of the sensitivity to the medication. Okay, moving on to the S. The S in close stands for seizures. Clozapine lowers the seizure threshold, and this is dose dependent, or there seems to be a dose relationship at least. So people that are susceptible or vulnerable can get seizures on clozapine. Sometimes this can be sort of helpful. In my patients that are doing ECT, the ones that are on clozapine, it definitely seems to be easier to induce a therapeutic seizure, but you also got to be mindful of the potential for prolonged seizures if they're doing ECT. And then also watching out for any other proconvulsant medications or substances. They have a comorbid alcohol use disorder and the potential for withdrawal seizures and all that stuff. The last one is E, and this is also a little bit of a stretch, but E stands for early expiration in the elderly, because the last boxed warning is actually increased mortality in elderly patients with dementia-related psychosis. And this is a shared warning with all antipsychotics. So that's not unique to clozapine, but there's about a twice increased risk of mortality in dementia patients with psychosis when they're put on antipsychotics. Now, this is an association. It's never been proven. Obviously, we can't do an RCT to demonstrate this with enough power because it's still ultimately a rare event. But from all the observational data, I think it probably is causal. All right. Well, that is pretty much all about the box warnings. In terms of dosing, the therapeutic blood level range for clozapine is around 350 to 600 nanograms per milliliter. Now, in my experience, I've definitely had plenty of patients who respond to significantly lower dosages than that. I've had some very good responses at doses as low as 75 or even 100 milligrams a day. So ultimately, you're going to be guided by the clinical response, not the blood level. But the blood level is definitely helpful in cases where you're not yet seeing a response and you're trying to decide how much higher you can go. So just to recap, using clozapine, you got to remember your black box warnings. And I made a mnemonic for that called CLOSE, CLO. And you can remember that by saying you need to closely monitor your patients on clozapine. And C stands for carditis, short for myocarditis. L for lymphopenia, to remind you about the risk of neutropenia. O for orthostatic hypotension. S for seizures. And E for early expiration and early death in the elderly. And that's specifically increased mortality in patients with dementia-related psychosis. And then dosing, we're going to start low. But we can fairly quickly ramp up. We're just trying to get those alpha-1 receptors sensitized to clozapine and not overdo it. So you're going to start at 12.5 milligrams to 12.5 milligrams twice a day to start. And you can go up by 25 milligrams to 50 milligrams every day until you reach a therapeutic dose. You're going to get weekly CBCs that will include an absolute neutrophil count for the first 6 months of therapy, and then you can decrease the frequency to every 2 weeks for months 6 to 12, and then monthly CBCs after the first year. Some guidelines recommend you get a baseline troponin and CRP so that if someone does have chest pain, you can, have a baseline to compare if it's truly elevated or not. So yeah, that's pretty much all I can say on my commute here. Definitely more to talk about with respect to clozapine, but maybe that'll be another episode. All right, take care.